So, as you can see, this is basically a systematized error in surgical practice. I mean, it's basically a practice that has been adopted as a result of a cognitive error in gynecological surgery. And I'll tell you what I mean by this cognitive error. You see, in general surgery and in thoracic surgery, when there's a mass that we want to deal with as surgeons, we assume that these masses have a malignant potential until proven otherwise. So our operating assumption is that the mass may have malignancy in there simply because if we don't make that assumption, the outcomes for the women who do have cancer is catastrophic. In gynecological surgery, the cognitive error that's been made is that there's an assumption of benignity. So these surgeons are assuming that most uterine fibroids are benign and therefore proceeding with an operation that's in no way oncologically safe. So that's a cognitive error. Now, what's remarkable to me is that a good number of GYNs were actually aware of this hazard for 20 years. If you talk to any GYN, they'd say, yeah, well, I've heard about it, and or maybe it happened to me once or something like that. But then you ask them, well, why is it that you didn't say anything about this? Why is it that you weren't more vocal? And in fact, a few people were vocal about it. They tried to stop it through the academic path, and they were unsuccessful at it, unfortunately. They were sort of blunted. So the question is, why would you continue doing this if you knew of the hazard? And the answer uniformly is that this procedure benefits the majority. So in other words, this is for the benefit of the majority. And at that point, I sort of came to a pause when I heard this argument because it's being used quite routinely, and it's being used by very prominent individuals and very prominent organizations. In fact, the American College of Obstetrics and Gynecology, the American Association of Gynecological Laparoscopists, they all essentially say that this procedure is benefiting the majority of women who undergo it, and therefore it's acceptable. This collateral damage essentially is acceptable. Now, in surgery, there are procedures that we do, and some do cause harm. But in many of those cases, in most of those cases, in fact, I hope, the issue is that those are accidents or they're unavoidable errors. If a patient develops a wound infection, if a patient develops an infection, a urinary tract infection, a pneumonia, or if even if the knife slips and you cut a blood vessel and the patient bleeds, these are accidents. In the case of morcellation, we're talking about a routine. We're talking about the systematic practice of mincing up tissues inside a woman's body without knowing if a cancer is present there or not. That's not an accident. That's a routine. And that's what makes it ethically suspect. So this benefit of the majority argument, as far as I could see, is something that really is a very significant violation of this medical ethical principle, the bedrock medical ethical principle that we know of as non-malfeasance. That is, that every single one of your patients has to matter. In particular, with surgeons, if you the only person that matters is the one in front of you. And if you start thinking about the benefit of the majority when you're treating Mrs. Smith, or in this case Dr. Reed, why you can cause very significant harm. And so your job as a physician treating an individual patient is to exercise non-malfeasance, which means that if there's something avoidable that could be harming that patient, you should not do it. So this is the cognitive error and the medical ethical error that has transpired here. And then the other question, which I think from a policy standpoint becomes very, very important, and the question that sort of came to my mind, and I'm in no way a politician. I am not even a patient advocate, really, frankly. I'm a general surgeon and a cardiac surgeon, and I hope to get back to my business soon. But the question that immediately occurred to me is, well, these devices that do this, they're very specifically designed for this purpose, and how is it that they've survived in the marketplace for almost 20 years without anyone picking up on this issue? And when I look back, the answer is very, very clear. There's there's a device legislation, the federal device legislation, which is known as 510K. This is a streamlined process for approval of medical devices, and essentially it has two features which are very, very dangerous. The first feature is that it's based on predicate devices, meaning that if a device is proposed by the manufacturer to the FDA for approval, if a pre-existing device similar enough to it exists in the marketplace, the FDA almost automatically rubber stamps this thing. But perhaps the more important issue here is that within 510K, once a device is marketed, there's absolutely no mandate for outcomes, for adverse outcomes to be reported back to the FDA or to the manufacturer by the individual practitioner. So, here it is. Essentially, the government has left this up to personal responsibility on the part of the professionals. And we would hope that most professionals will take responsibility and not want to harm patients. But the fact is that in this case, this has failed very dramatically. Up until November of 2013, when this happened to Amy, 20 years after these devices have been in use, the FDA hadn't even heard about this outcome. And meanwhile, this is affecting 1 in 350 to 1 in 1,000, pick your number, whatever number it is, it's somewhere in the 1 in 350 to 1 in 1,000, for close to 20 years, and the FDA did not know about this. So the device legislation is very clearly deficient. This 510K is itself a public health hazard. Now, what to me was remarkable was the discovery that in 2011, at the behest of the Senate Help Committee, which is the Health, Education, Labor, and Pensions Committee of the United States Senate, and I believe that Senator Harkin was involved with this, a review was performed of 510K by the Institute of Medicine. And in 2011, the chairman of this committee testified before the Senate Help Committee and essentially demonstrated and warned the Senate that this particular piece of legislation does not ensure patient safety. And this was very, very clear. I mean, this was, the IOM did not mince any words on this piece of legislation. This does not ensure patient safety. And well, here it is. In 2013, this has come to roost for the United States Senate. And I hope that the senators of the Health Committee, including Senator Warren and Senator Franken and Senator Harkin, all of whom are really champions of patient safety and the champions for the downtrodden, frankly. Their political agenda is one of liberal Democrats. These individual senators need to step up to the plate, and they need to review this 510K legislation and fix it. Because I can guarantee you that this is not going to be the only example out there. There are other examples, perhaps not as dramatic as this morcellator issue, but they're going to be out there, and they're flying under the FDA radar screen. So we hope that we can actually fix this problem at the level of legislation. But most certainly, this morcellation and the morcellators need to be banned. I mean, this is a practice that has devastated many lives. I mean, we have talked to every single one of these women in this picture collage, and I can tell you that there are examples of women on this collage who have had young children, left them behind. The economic and the emotional and social costs of this thing have been enormous, and it's time for it to stop, frankly. So I'm very optimistic that the FDA Commissioner and Dr. Lori, the Associate Commissioner, as well as Senator Warren and Senator Harkin and Senator Franken will protect the public, as is their responsibility at this point. This is not a matter of patient choice. Bad medicine should never be a matter of patient choice. And in fact, the industry is standing up, the profession is standing up and saying this is for the benefit of the majority and that this is a woman's choice. Now, those are sacrosanct words in our society. They speak to democracy. They speak to a woman's choice. And of course, I won't presume to negate the value of those arguments. However, if they are being used to defend and protect what is a public health hazard, I think the corporations and the specialty are really walking on very thin ethical ice, and I think that needs to stop. So I have a couple of comments here. Ms. Chambers is saying that are you aware of the excellent proprietary analysis of medical devices by a California company? The industry knows about this. Patients do not. Yes, and in fact, I think the reason why some very distinguished Democratic senators have not addressed this is because it's not in the public eye. I think that if this issue were in the public eye, I think Senator Franken and Senator Warren would have an extremely difficult time explaining how inconsistent this is with the agenda on which they ran for office. And I'm very hopeful. Amy and I have met with Senator Warren, and I'm very hopeful that her orientation will be one of strong support, and that she'll stand up and fight with us to change the 510K legislation, because I think that's basically the blood supply of this monster. And we're committed to use this example and to use the media to get this out in front of the United States Senate so they can fix 510K. This needs to be fixed. And we're frankly not arguing for increased regulation. We're arguing for patient safety. And I don't think Senator Franken will disagree with the notion of patient safety. If 510K does not ensure that FDA-approved devices have a mechanism for reporting adverse outcomes directly to the FDA and to the manufacturer by individual practitioners, then 510K is unsafe. And I don't think any senator, doesn't matter if they belong to the left side of the political spectrum or to the right side of the political spectrum, would disagree with this concept that we need to keep patients safe. Everybody's mother, everybody's daughter, everybody's sister needs to be protected from this kind of thing. This is not a partisan issue. This is completely bipartisan. To give credit where it's due, I think most physicians who I know have the intent of helping people and protecting their patients. I don't think there's any sort of individual malice or even individual negligence here. I think that this is an example of a collective blindness to a particular hazard because of the way the education of these surgeons and gynecology takes place. Gynecologists train away from other surgeons. So if gynecologists had trained with general surgeons, as other surgeons do, I think they would realize that you can't mince up someone's enlarged tissues inside their body and expect that everything will be okay. The concept of assumption of benignity, meaning assuming that the tissue is benign, is a flaw, is a dramatic flaw, and it needs to be corrected. So again, I would like to reiterate that this is not in any way a personal attack on anyone. Most doctors I know have worked very hard throughout medical school and residency. Most doctors I know have the intent of helping people and doing good in this world, but mistakes happen, and cultural blindness does happen. We don't have to go too far back in history to find examples of cultural blindness leading to real major problems. So I think what I'd like to do is I'd like to frame this as an industry-wide problem in GYN. However, now that the hazard has been shown, if individual gynecologists or gynecological societies do not look with care, with sufficient care, this will be an industry-wide and individual act of negligence at this point, because the data is clear, because the victims have been shown, the monster is in the light, and they need to act on this. They need to wake up and get their heads out of the sand and fix this problem. Ms. Shinazi is saying, what does the hospital offer women now? Abdominal incisions, vaginal removals? Are there any other choices? Yes, there are other choices. The choices would be, I think, minimally invasive surgery is possible. In fact, general surgeons, thoracic surgeons do minimally invasive surgery without mincing up tumors. The way you would do this is you would do your dissection using a laparoscope or with robotic surgery, and then when it comes time to removing the tissue out of the body, you either do it through a transvaginal route or you make a small mini laparotomy incision and you take it out of the abdominal cavity. In most of those cases, patients can actually go home the same day. And I think that this is a very very critical point, that there are alternatives. This is not an unavoidable practice. When I do cardiac surgery on patients and we put the patient on a heart-lung bypass machine, we don't have a choice there. We have to accept that there's a up to 10% chance of causing renal failure. That's unavoidable with the current state of technology in that case. And if we don't do those operations on patients, they could die. In this particular case, there are other alternatives. There are, in fact, alternatives for doing minimally invasive surgery, even through a transvaginal route or through a mini laparotomy route. What the gynecologists have to give up is this concept of this assumption of benignity, that uterine tumors are benign. They are for the most part, but in 1 in 350 women with symptomatic uterine fibroids, they are not. And those are the women whose lives get completely devastated when morcellation happens.